Hello guys, welcome to MediBliss Unlimited. Today we are going to study about one of the important topic of gastrointestinal tract, that is Zollinger-Ellison syndrome, GD syndrome we commonly refer to. Now let's begin studying GD syndrome. It is caused by gastric secreting neuroendocrine tumor, which are commonly referred as gastrinomas. Remember this, these are gastrinomas. Next, we are going to cite the most common site of Zollinger-Ellison syndrome. It is mainly the duodenum which is involving and get damaged. JD syndrome mostly involves duodenum, followed by pancreas, and then the stomach. Stomach is the last important factor. In gastrinomas, these are solitary or multifocal nodules. Generally, these are associated with MEN1 syndrome. There are other associations of MEN1 syndrome: pituitary adenoma, pancreatic adenoma, and parathyroid adenoma. Let's go to the clinical features and presentation. CF means clinical features. In clinical features, we get chronic epigastric pain. The patient may be feeling pain which is more than 6 weeks or 3 months. Use or abuse of PPI. The most common etiology of JD syndrome is the use and abuse of PPI. Prolonged usage of PPI, proton pump inhibitors, they are lansoprazole, omeprazole, and diarrhea. Diarrhea is the most important factor which helps to rule out the H. pylori, because in H. pylori there is no diarrhea symptom, and weight loss here also is there. H. pylori rule out is a major important factor because when you are attempting MCQ, H. pylori does not indicate the diarrhea. Next, GARD, gastroesophageal reflux disease, one of the important factor. Family history or past history of kidney stones. These are stones, not stones, kidney stones. It is also a risk factor for clinical feature of JD syndrome. Pancreatic enzyme inactivation by acid leads to maldigestion and malabsorption. Next, we go to JD term called triad of JD syndrome, which include peptic ulcer disease, gastric acid hypersecretion, and pancreatic tumor. Next, workup, which can also called as investigations. Investigations, we have upper GI endoscopy. Investigation of choice, it means most of the important investigation: increased fasting serum gastric concentration, that is more than 150 pg per ml, picogram we can refer. Measurement of gastric pH. In gastric pH measurement, we usually use a probe which is used for finding the pH. Here we can draw, I am drawing here. We insert a probe here, LES, lower esophageal sphincter. This probe goes to here, 5 centimeters below and 5 centimeters above the LES. Next, we have secretin stimulation study to differentiate from other hypergastrinemia. High serum calcium suggests hyperparathyroidism and MEN1 syndrome. Here, MEN1 syndrome association, you can see the parathyroid adenoma, which can use to PTH, serum calcium. Next, we will go to imaging studies. Imaging studies have some importance here. In imaging, we have somatostatin receptor imaging with SPECT. SPECT, which is means single proton emission computed topography. It is CT means computed tomography. It is single photon emission, matlab, which it includes only one photon on imaging. Endoscopic ultrasonography, which also a studying of the mucosa of GIT. Next, CT and MRI to detect liver mets. Here mets means metastasis. Hepatic wedge resection, most common metastasis. Imaging increase in calcium and PTH, parathyroid adenoma. We also studied here high serum calcium for hyperparathyroidism and MEN1 syndrome. Here parathyroid adenoma, cestum EB scan. It is cestum EB scan. Next, at last we will go to the treatment. Treatment include proton pump inhibitors, which is also seen omeprazole, lansoprazole. And next, surgical resection or cryoablation for single mets. Most commonly involved is liver. Thank you for watching my video.